Buenas tardes. Siguiendo con el programa, vamos a tener una conferencia magistral de un profesor cuyo apellido va a pronunciar enseguida Juan Esteban Carranza. Juan Esteban es el director del Centro de Estudios de Economía Industrial del Banco de la República, que ha apoyado la realización de este evento. De manera que le cedo la palabra a Juan Esteban para que presente al doctor Gautam. Adelante.
Buenas tardes. Me encanta participar de este congreso. Una de las funciones del Banco de la República es apoyar la creación y difusión de conocimiento en economía y pues esto es precisamente lo que estamos haciendo. Hemos invitado al profesor Gautam Gowrisankaran. Él es doctor en economía y es profesor de la Universidad de Arizona. Su especialidad es la organización industrial empírica y a lo largo de su carrera siempre ha tenido un interés especial por el entendimiento de los mercados de salud. Nos va a hablar hoy del comportamiento de los consumidores de salud en Estados Unidos cubiertos por el programa Medicare Part D. Para aquellos que no saben, el programa de Medicare es un programa de aseguramiento universal en salud para todos los mayores de 65 años en Estados Unidos. Es casi universal. Y lo que se llama Part D es una porción introducida recientemente durante el gobierno de George Bush de cubrimiento de medicamentos. No hay ninguna selección de las personas, básicamente todo el mundo se inscribe y el cubrimiento, la forma como cubre a todo el mundo es la misma. Y la particularidad que va a explotar Gautam para explorar los incentivos dinámicos de los consumidores es una cosa que se llama el hueco de la dona, el donut hole, que es que se refiere a una brecha que hay en el cubrimiento anual de los gastos en medicamentos por parte de cada uno de los asegurados, y consiste en que el sistema cubre los gastos hasta un umbral, cubre el 75% de los gastos en prescripciones hasta un umbral de $2.500 anuales cada año. Una vez el gasto total sobrepasa estos $2.500, no hay ningún cubrimiento. Y cuando el gasto sobrepasa los $4.000, si no estoy correcto, bueno, ahorita les da el número más preciso, empieza de nuevo un cubrimiento ya del 100%. Entonces hay una brecha de cubrimiento que genera incentivos para las personas de hacer sus compras de una u otra forma de los medicamentos a lo largo del año. Cada diciembre se reempieza a contar este gasto. Entonces, le cedo la palabra a Gautam y aprovecho la oportunidad para agradecer su amabilidad e interés de venir a este congreso.
Buenas tardes y muchas gracias a Juan Esteban. Quiero agradecer a todos las organizadoras y todos para la invitación a venir a Colombia. Es mi primera vez y voy a hablar del Medicare Part D. Voy a hablar en inglés porque mi español no es demasiado fuerte. So I'm going to talk about myopia and complex dynamic incentives. And this is joint work with Tina Dalton and Bob Town. And it's about the US healthcare system, as Juan Esteban said, but I think there's a lot of similarities with understanding, it's about myopia more generally, and there's a lot of similarities with the Colombian system, which from my understanding works on a similar basis to much of what the US is moving to, which is a private provision of healthcare with public mandates so that people have to buy the insurance and stuff. Okay? So as Juan Esteban said, Medicare Part D is prescription drug coverage for people age 65 and over. And it's the largest and most important benefit change to Medicare since its inception. So what Part D did was it added drug coverage to the existing hospital and physician and outpatient benefits. And it was passed by President George W. Bush with bipartisan support from both Democrats and Republicans. And the cost of Medicare was $66 billion in 2012. The program is very popular. It enrolls 43 million beneficiaries, and virtually all senior citizens are covered by Medicare Part D, over 90%. And the program lowered out-of-pocket costs and increased prescription drug coverage. The biggest criticism of Medicare Part D is what's called the donut hole benefit structure. So insurance stops when spending reaches the donut hole. In 2008, the donut hole starts at $2,510 in total expenditures. So during a calendar year, if a Medicare Part D enrollee has spending, including her spending and the insurance company's spending, that's in excess of $2,510, then after that, she has to pay out of pocket for all of her expenditures. And the benefits don't restart until what's called the catastrophic coverage zone. And in 2008, the catastrophic limit is $4,050 in out-of-pocket expenditures, which corresponds to about $5,500 in total expenditures. So between $2,500 and $5,500, or about $3,000, people in Medicare Part D are responsible for paying all of the expenses that happen. The donut hole is very unpopular. 1/3 of Medicare Part D enrollees entered the donut hole in 2008, which is the year of our sample. And critics suggest that it leads to adverse health consequences by reducing the consumption of medications. The 2010 Affordable Care Act, which is also known as Obamacare, phases out the donut hole. And even though you might hear a lot about, in the United States, about people wanting to repeal the Affordable Care Act, to get rid of it, nobody's talked about getting rid of this part, because everybody wants to get rid of the donut hole, which is what the change in the Affordable Care Act does. Importantly, by having a donut hole benefit structure, it creates a complex dynamic decision problem for Medicare enrollees, okay? So if you're a Medicare enrollee, then what you want to be thinking about, if you want to really optimize with respect to this, is that you need to think, where am I going to end the year? And if I'm going to end the year before the donut hole, then effectively my last prescription is insured, and I should spend as though I'm getting insurance. But if I'm going to end the year in the donut hole, then at the margin, that last prescription, I'm paying for it completely out of my pocket. The insurance is inframarginal. From a point of view of a rational economic model, what I should do is I should act as though I'm not insured at the margin, because that last prescription, I'm not getting any insurance for. Okay, we'll develop I'll present a formal economic model shortly, but the idea is quite simple. If you're a rational individual following our standard economic models, then the only thing you're going to gain by changing your behavior in the donut hole is a small time value of money, really something where you're going to delay a payment over a week or 2 weeks, something that's a very small period of time. Okay, but does the rational model accurately reflect enrollee behavior for Medicare? So some studies find that in Part D plan choices, people are at least partly myopic. But other studies find that there's actually some rationality, that people act as though the future matters. The fact that different studies find different things suggests the need to examine rationality in this market further. And what we're going to think about here by rationality is really dynamic optimization. Okay, and dynamic optimization is required for many health insurance contracts. So, if you think about any type of health insurance contract that occurs in order to control costs, we have out-of-pocket maxima, we have deductibles. So any of these things create a dynamic decision problem. Okay, if you're going to have a plan where the enrollee has to pay for the first couple of $1,000s, then that means that they're going to be in the beginning, the first couple of $1,000s, they have to decide if they're going to end up in an insured region or a non-insured region. And more as we try to reduce healthcare cost growth and provide services in an optimal way in countries across the world, we're moving to have people pay more out of pocket at the margin. And this inherently is going to create dynamic incentives. Okay? So what we want to do in this study is to analyze the extent to which Medicare Part D enrollees act myopically in their choice of drugs, and to evaluate the extent of what we'll call behavioral hazard, which is how does myopia change the incentives and the outcomes in this market. So what we're going to do in this study is we construct a dynamic model of drug consumption, and the model allows for non-rational behavior, notably what's called hyperbolic discounting. We're going to use the model to motivate and develop a simple and robust test of myopia. The test is based on a regression discontinuity design. We're going to examine enrollees who arrive near the donut hole early in the year. Rationally, they should expect to reach the donut hole before the end of the year. And this results in a simple test to understand, because the donut hole for these people, this selected sample, has no bearing, because they're going to end up at the end of the year in the donut hole, they should not change their behavior upon getting to the donut hole. And we're going to examine whether that's true. Having found evidence of myopia, we then go on to structurally estimate the parameters of the model. And there's some econometric challenges there, and we develop methods to handle those econometric challenges. And we use our structural estimates to understand what is the policy impact of Medicare Part D's expansion under the Affordable Care Act of getting rid of the donut hole. Both our tests of myopia and our structural estimation framework may be more broadly applicable to understanding insurance. So we think that understanding myopia is something that is important outside of just the immediate context of Medicare Part D, and that this way of testing for it that's fairly robust might be of interest in other contexts, such as Colombian healthcare, for instance. So our study is most closely related to papers that examine Medicare Part D. So there's been work by Einab, Finkelstein, and Schrempf, and by Avalok, Gruber, and Swanson. And we developed complementary tests to the literature. So Einab et al. Estimate a structural dynamic model with an annualized discount factor of 0.02. And we propose a test for low discount factors and to separately identify them for myopia. And we develop a modeling framework that's more similar to standard dynamic multinomial choice models. And our identification uses actual price data and uses the period near the donut hole to identify it. And our model's also related to the literature that examines hyperbolic discounting. And I mentioned a couple of classic papers there. And our empirical modeling here builds on work by Fang and Yang and others that show how to model this, and then we use their framework pretty directly. The remainder of the talk, I'm going to go through the model, the data, the reduced form evidence for myopia, the econometrics of the structural model, results and counterfactuals, and the conclusion. So our model focuses on the dynamic decision of a single Medicare Part D enrollee. And when we get to econometrics, I'll discuss aggregation to our sample. And we model a Medicare Part D enrollee who reaches $2,000 in expenditures between April and July. Okay? So remember that the donut hole starts at $2,510. So these are enrollees who've already reached near the donut hole early in the year. And we're going to consider their decision process after reaching the donut hole. We're going to assume that these individuals will end the year in the donut hole, and the assumption is close to correct. I'll show you empirical evidence later. And the implication is that the donut hole is an absorbing state. So these individuals, having spent $2,000 in the first roughly 5-6 months of the year, know that they're going to spend at least $500 more in the rest of the year. Okay? At each week, the enrollee is faced with a distribution of health shocks. So at any point in time, the enrollee calculates a conditional distribution of future health shocks. Conditional on her type, each health shock is an independent draw, and there's a maximum of n bar health shocks in a week. Let Qn denote the conditional probability of observing another health shock, and note that Qn upper bar is 0, because you've already gone through all of them. Health shocks take on values h equals 1 up to capital H, and each one corresponds to a particular drug class. So an example is opioids, which are used for pain relief, or insulin sensitizers, which are for type 2 diabetics. And each health shock occurs with probability pH, and each health shock has associated drugs, J equals 1 up to JH, plus the outside option, which involves no treatment. So we're going to model a fairly standard multinomial logit model. So the flow utility from any drug treatment is a function of gamma HJ, which is the perceived mean utility fixed effects, the price, which is PHJ if the patient pays everything, or OOPHJ, which stands for out-of-pocket price, HJ, which is the price if you're in the insured region, and we'll put a parameterization alpha of P on that. And we're going to use a linear spline with 3 king points for that, and that allow for the flexible impact of price on decisions. We model IID shocks, epsilon HJ, that are type 1 extreme value, and so the flow utility before the donut hole is gamma HJ minus alpha out of pocket plus epsilon HJ, okay? And within the donut hole, you put in the full price of alpha PHJ. The outside option is the option of not picking any drug and foregoing your drug treatment, and that has utility epsilon H0. Substitution of the outside good is in the donut hole is important. It's empirically important, as we'll see when we get there. Okay, so our problem is dynamic because filling a prescription moves you closer to the donut hole. At any week, we're going to assume a model that's called hyperbolic discounting, which is a non-rational model. And so it says that an individual discounts utility from future treatments as beta for treatments this week, beta delta for treatments at next week, beta delta squared at treatments for treatments at time t plus 2. Okay? So why is this non-rational? Because the agents at time t value time t plus 1 and t plus 2 similarly. Okay? They value it by 1 over delta and assume that delta is very close to 1. But upon getting to next week, upon getting to t plus 1, they heavily discount their t plus 2 payoffs. They discount it by 1 over beta delta. And so they want to do different things now than, between their trade-offs between next week and the following week than they would do if they get to next week. Okay, so in other words, what they'd like to do is they'd like to commit to future actions. They'd like to tie their hands now and say, next week when I get there, I'm not going to overspend and buy the expensive drugs. But there's no mechanism in Medicare Part D to get them to commit to those future actions. Okay, so they're myopic. And in the literature, these agents are called sophisticates because they're myopic and they know they're myopic. They would like to commit to future actions, but they can't. So the agents optimize at each state, and they take as given their future actions, and they play a Nash equilibrium against their future selves. And we can model this similarly to a Bellman equation, and this is where we follow closely the modeling framework of Fang and Yang 2013. Okay, so I'm going to go through a couple slides on the Bellman equations, and then I'll get back to more of the healthcare on it. Okay, so the state space is M, the dollars till the donut hole, and recall that the donut hole is an absorbing state in our model. N is the number of health shocks in the week, and the gross value we'll call V delta, and that's the payoffs gross of this hyperbolic term. The net value is conditional on a health shock, and so it's a function of Mn, epsilon, and H. And the effective price is just going to be equal to the full price if you're in the donut hole or near it, the out-of-pocket price if you're far from the donut hole, and some mixture if this drug brings you into the donut hole. The net value here, so this is going to look like a Bellman equation, but it's not exactly a Bellman equation because you're non-rational in your decisions. Okay, so the net value depends on the future gross value, and this looks like a Bellman equation, except we have a beta term sticking over there. And the shares follow multinomial logit share patterns. This should look familiar to anybody who knows multinomial logit models. But where it's different is that the gross value depends on your probabilities, and you're not actually optimizing with respect to your future selves. You're doing something that's a little bit wrong, and because of that, we have to put in this correction term that accounts for the fact that you're actually making the wrong decisions. Okay? So, and this again is just building on what's been done before. So now I want to get to more of the economics under it. So what are the implications of the model? Well, let's start at the implications of the model if there's no discounting. Okay, so the simplest case, we're just going to consider a very simple case. Okay, so forget about the whole dynamics that I showed. This is really simple. There's one health shock and one drug. Okay, so H equals 1 and J equals 1. And we'll make it really easy. So let's say that the price of the drug is exactly $100.40 and that you pay exactly 1/4 out of pocket. So why did I chose those numbers? Because it means that there's exactly 25 drugs for which you're insured, and the 26th drug you pay out of pocket. Everybody follow? Okay. So consider again that beta equals delta equals 1. So there's no discounting, there's no myopia. Okay, and for tractability, just assume that the decision ends at some faraway finite time. And so all that matters now is the end of year price. Okay, how do we know this? Because remember, we're conditioning on a set of people who are going to end up in the donut hole.
Okay, so instead of thinking about this as insurance, we could think about it like we're going to give the people a check for 3/4 of the donut hole for $1,882.50, and then we're going to tell them you don't have insurance. Okay, so that's exactly identical to our model. And if you actually did this, then you'd see people don't have really insurance, they just have a subsidy. And when you have a subsidy, not an insurance, the takeaway is that there should be no change in behavior upon crossing into the donut hole. Okay, and remember, we're only considering people who know they will hit the donut hole at some point in time. Okay, and what if we had like multiple drugs or multiple drug classes as we do in reality? Well, the intuition is more complicated, but there's a similar idea. Okay, and what about the case, you might think, well, gee, what if I value this treatment at $60? Okay, so then you might say, well, I'm going to buy it if I'm insured, and I'm not going to buy it when I'm not insured. I value it somewhere between out-of-pocket price and price. Okay, that's not our sample, because in that case, the spending would stop when you get to the donut hole, and that's not true in our data. For the sample of people who reach 2,000 expenditures early on, they mostly, and I'll show you a histogram of it, end up well in the donut hole. Okay? So now let's consider a variant of the model where there's geometric discounting, so people are still rational. Okay, now let's compare the last insured purchase to the first non-insured one. Okay, if you purchase at the last insured time, you pay $25 immediately, and then you move up the insured payment by one purchase occasion. Versus at the 26th time, the enrollee pays the full $100 immediately. Okay, so the difference between the last insured and the first non-insured is only the time value of $75 over the period between purchases. Okay, so all you're getting is that you're postponing the receipt of $75 by a couple of weeks or a week or something like that, okay? Now, if we compare the 24th to the 26th period, then the enrollee gets the same value of $75, but the time period she gets it for is twice as long. Okay, the implication is going to be that if there's an increase from the 24th from the 25th to the 26th purchase, the increase in probability of buying the drug at the 24th purchase is about twice as high. Okay, as you move further back from the donut hole, you're going to see just an almost linear progression away from it. This geometric discounting is going to yield a geometric progression in purchases away from the donut hole. Okay. Now let's consider a model of myopia. Okay, so myopia says that beta is less than 1, or total myopia is delta equals 0. Compare again the 25th and the 26th drug purchase. So the difference is still the value over $75 between purchases, but we're now discounting it by beta delta to the t, where t is the expected time until the next purchase, and the difference in values is now 1 minus beta delta to the t times $75. Okay, the implication is that if you're myopic, if beta is a lot less than 1, you can have substantial differences in decisions between the 25th and the 26th period. Now let's compare the 24th to the 26th purchase period. The $75 is now discounted by beta delta to some t prime, where t prime is bigger than t. But importantly, these two discounting can be very similar because what's driving it is the beta, it's your myopia. It's not the actual time value of money of a rational geometric discounter, it's the fact that you're a myopic individual who discounts any future action a lot that can generate that you suddenly drop your prescriptions when you get into the donut hole. Okay, so importantly, the implication is that the myopia allows for the 24th and 25th purchases to have similar probabilities, but a big drop at the 25th. Okay, so what are the normative implications of the model? Well, health insurance generally leads to overconsumption. So we set prices below costs, and that leads to moral hazard, at least from a simple economic point of view. So if we think about the planner having beta equals 1, and the Part D enrollees having beta less than 1, then enrollees are going to further overconsume in this initial coverage region. That's going to result in more deadweight loss, and the implication is that donut holes lower welfare. So in fact, if you have myopia, then what you'd like to do is have deductibles, because they have the opposite impact and can counteract moral hazard. Okay? Like basically, if you have a deductible, people think they're not insured, but they really are insured for serious illnesses, and that's actually good. Okay, and the real world is more complicated than this story because we're only considering drug purchases here. And if you don't take drugs, then that may lead to hospitalization. And so, if you don't take your insulin sensitizers, maybe you get hospitalized for diabetes, and that's a lot more costly. So I don't want to stress, I don't want to hang my hat on these normative implications, but for what they are, I thought it's useful to present them. Okay, so we have Medicare Part D claims data on employer-sponsored plans. So as Juan Esteban said, Medicare Part D is a near universal program for drug coverage, and this is one particular segment of the market where people who worked for firms that were relatively generous will get insured by those firms later on. I guess it's similar to the fact that like the railroad workers or the military in Colombia get insured by their employer, not by the public scheme. So the data are from 2008, the third year of the Medicare Part D program. So it's not that people know nothing about this, they're pretty informed. And they're from Express Scripts, which is a large benefits manager. That we focus on plans that have a standard donut hole design. And we have claims from 5 plans and 2 employers that cover 32,000 enrollees. Each plan has a coverage gap starting at $2,510 in total price. And we also do falsification from a plan with a coverage gap that starts at $4,000. The employer-sponsored plans are an important segment of Part D. Almost 7 million enrollees, or 15% of Part D enrollment in 2008, is employer-sponsored plans. And we use most of the enrollees for the employers in our sample, which means that we can minimize some of the selection issues. And also, this segment has higher income than average. To the extent that high income or high socioeconomic status is correlated with less myopia, our results are going to understate the level of myopia in the general American population. Our Express Scripts data contain all the claims from each enrollee, enrollee identifiers and dates, drug names, types, and NDC codes, which are national drug codes, out-of-pocket price, and the total price billed to the insurance company. We combine the data with the ACG score data, and this was developed by Johns Hopkins, and it provides an expected pharmaceutical cost. So in our case, the input is individual pharma claims between January and March 29th, 2008, and we're going to use those as a predictor for the pharma claims during our sample. And our structural isolation is going to stratify all the parameters based on the ACG score. So as I said earlier, we keep this sample of patients who reach $2,000 in total spending between Sunday, March 30th and Saturday, July 26th. So both the reduced form model and the structural model are driven by this regression discontinuity of people near the donut hole. An observation is an enrollee week. We keep weeks starting with the first complete week over $2,000, and the sample extends to the last week in the year that starts under $3,000. We classify each drug into a disease category based on the function of the drug, and we lump together small disease categories. Here are some summary stats on our data and enrollment. So we have data from 2 employers, and then we have the falsification employer, that's 3. For the employer 2, we have every claim. And for employer 1, we drop a couple of plans which had more generous coverage. So these numbers don't add up to 100, they add up to about 80%. Okay, these plans are very similar. So their deductibles are pretty low. The donut hole starts at $2,510, and the catastrophic coverage starts at $4,000 and a little bit in out-of-pocket dollars. The total enrollment for these plans is about 25,000. And from these, the percent that actually hit the donut hole is about 20% in this and less for these. And the percent that hit catastrophic coverage is about 1%. Okay, from this, we create this estimation sample that's a selected sample of people who spend a lot, spend $2,000 or more, spend $2,000 and hit that mark between April and July of 2008. Okay, so our selected sample includes this many enrollees. There's about 2,000 of them. And among those employees, 97% actually hit the donut hole. Okay, so our theory was predicated on the fact that most people are going to hit the donut hole, and that's actually quite accurate. About 10% hit the catastrophic coverage, and we don't deal with that in the theory, but we show later that any results we found are going to be actually mitigated by this, and so our results on myopia are stronger than they would appear. The mean total spending is right in the middle between the donut hole and the coverage gaps. The coverage gap starts at about $5,500 in total spending, and the mean out-of-pocket spending is about $2,000 on average. The average age in this population is 74 or so, the minimum age is 65, and it's about 60% female on average, and this is the ACG score where 1 is the population average among Medicare enrollees. The most common drugs in our sample are cholesterol-lowering drugs, the most common drug classes, renin-angiotensin system blockers, which are used for blood pressure, beta blockers, which are also used for blood pressure, opioids for pain relief, antidepressants for depression, diuretics, etc. The most common drugs in our sample include hydrocodone, which is an opioid, lisinopril, which is a renin-angiotensin system blocker, simvastatin, which is Zocor, I think, And 9 out of the 10 most common drugs are generics. The only one that's not a generic is Plavix, which is an antiplatelet. And we aggregate the drugs, so we have 306 distinct drugs in our structural estimation. Okay, so again, now I'm going to talk about our tests for the low discount factor and hyperbolic discounting. So we're going to estimate a series of regressions on the sample of enrollees who arrived near the donut hole early in the year, starting at $2,000 in total spending. And for this sample, that we should the same future prices. They have the same future prices but different current prices, and rationally they should react principally to the future prices. We're going to use this RDD approach of people near the donut hole, which minimizes the possibility that factors other than the donut hole might be influencing our findings. So using this sample, we're going to do simple linear regressions of the form YIT, which is some variables like number of prescriptions in a week or amount of drug spending in a week, a fixed effect for the individual, an indicator for whether you're very near the donut hole, which we're not going to report in because then in that case a drug might push you over the donut hole, and an indicator for whether you're in the donut hole. So we're going to ask whether if you're in the donut hole, do you reduce spending? Okay, before I present the linear regressions, I'm going to start with non-parametric regressions that are done in Stata using the low-S command. Okay, so just simple non-parametric regressions to look at what we find. Okay, what we see here is the mean spending during the week, and what we see is that until about $2,350, $2,400, the mean spending is flat, and then it drops a bunch, about 25%, and then it's flat in the donut hole. Okay, so again, this is fairly strong evidence of myopia. There's no reason, these are people who know if they're rational, should know that they're going to hit the donut hole at some point in the year. There's no reason at all for them to change their spending upon hitting the donut hole. So we think it's the fairly robust evidence that people are not acting like traditional dynamic consumers in this market. Okay. This is a falsification exercise. We took that plan, CL3A, where the donut hole starts at 4,000, somewhere out there, and we look and see, is there some difference at 2510? No, there's no difference, okay? It's really flat. So it says that it's not something medically about hitting 2510. It's in fact the fact that you suddenly get this bill and you say, boy, I have to pay, $90 for this, not $22. I better not buy it, okay? Then this is total spending near the $4,000 falsification plan. So this is asking the question that this is the coverage gap for the falsification plan, and we observe something similar, although the spending is kind of dropping. So it looks a little bit more like they're rational in the sense that this line is sloped rather than it being flat right near the coverage gap. Now the sample size here is much smaller, so I don't want to make too much from it. And this is the total spending near the catastrophic coverage for the base sample. And again, it looks maybe slightly more like you've got a low discount factor, but you're a rational individual because it's sort of ramping up here, and then it's flat once you hit it. Okay, and again, this is a very small number of people that actually hit these coverage gaps of higher levels, and so I don't want to make too much from it. Okay, so do people who end the year at the coverage gap start, is it true that there's a lot of bunching? This is our full sample. You can see that there's what's called bunching, that a bunch of people stop at 2,500. Okay, that's not true for our estimation sample. This is our estimation sample. This is a histogram where they end the year. There's no excess bunching here. There's nothing like people are stopping right there. So people rationally, again, should be expecting that they're not going to stop at 2,500, that they're going to surpass it and be somewhere in here, that they're going to rationally surpass it quite a bit. Okay, having presented the non-parametric regressions, here is a backup sort of linear regressions that show the same thing. Okay, what we found there is that the mean drug spending was $61 and it goes down by about $18. Okay, so that means it goes down about, what is that, 30% or so. The total price per prescription goes down about 12%, and the number of prescriptions also goes down about 20%. Expensive prescriptions, branded prescriptions, go down a lot more than generic prescriptions, and expensive prescriptions, those that are $150 or more, go down by 33%. Medium price prescriptions between $50 and $150 only go down about 25%, and inexpensive prescriptions really have no change at all. Okay, so people are cutting back on prescriptions. 10 or how many minutes? 15, thank you. Okay, people are cutting back on expensive prescriptions, and they're not cutting back on cheap prescriptions. They're cutting back on branded ones, and they're not cutting back as much on generic ones. They're still cutting back some. Okay, This is the behavior in the coverage gap with another dummy to understand whether it's myopia or simply low discount factors. So again, what we do is we put in dummies for the 2200 to 2400 range. So we can say, are you sloping downwards towards the donut hole, or are you just kind of flat and then you hit the donut hole and you crash, you lower your spending? Well, you already saw the graph. It doesn't show any slope, right? It shows you're really flat till about 2350 to 2400. So this is just backup of that. The coefficients on these are roughly the same as before, and the coefficient on this is insignificant and very close to zero. Only one of them is sort of marginally significant, okay? So you don't do any spending drop in the 2200 to 2399 effect. Okay, the takeaway is that there's this no geometric pattern of drops approaching the donut hole. What I want to now look at is focus on different drug classes. Okay, so we looked at the 5 largest changes in drug classes and the 5 smallest ones. Okay, the 5 largest ones should be very familiar. They're like among the 6 largest drug classes overall. Okay, and the 5 largest increases, the increases first of all are almost zero. There's nothing significant here, and they're for tiny, tiny classes like folic acid, and antagonist antibiotics. I think, you know, folic acid for pregnant women, not too many pregnancies in the over 65 class, right? That's a joke, you should laugh. Okay. So, you know, so I don't think it's that common among the Medicare Part D enrollees, okay? So now the takeaway from this is actually that not exactly what I said, I updated it. There's no clear pattern of heterogeneity except opioids. So the one thing where people are not cutting back much is pain relief. Okay, again suggests that, you know, people are saying, I don't need to take my cholesterol lowering drugs, I don't need to take my beta blockers for hypertension, but I do need to take my opioids, right? That's the one thing that they don't cut back on as much is pain relief, okay? So interpretation, the reaction to the current price is evidence of a low discount factor or myopia. The lack of significance in the 2200 to 2400 region rules out geometric discounting with low but a positive discount factor. We don't account for people knowing they might end up in the catastrophic region. 10% of enrollees in our sample eventually do end up there, but this is going to bias the coefficients towards zero. People with more spending will see a higher price, while we're going to put in a lower one. The falsification exercise, no change at 2510. The behavior near the catastrophic start looks a little more geometric. Seniors are provided good information about the donut hole. Okay, so in case you're thinking it's just an information story, here is a statement from Bob Town's mother, my mother-in-law, my co-author's mother-in-law. And this is from a later year, so it says, you know, this is part of a statement. It says there's an initial coverage region. You stay in this region until your year-to-date total drug cost reaches 2850, not 2510, it's a later year. Okay, once you have an additional 2528 in total drug costs, you move to this region. It's called the coverage gap or donut hole, and you generally stay in this stage till you reach the catastrophic region. Okay, so Medicare Part D enrollees are given these statements like every month. They're given updates on it. So, you know, clearly it's not getting through, but it's not a question of like they just didn't know about it, right? They know about it. They're faced with this year after year. They get these statements. Okay, now what I'm going to do is do the structural estimation. So denote the individuals, I equals 1 to capital I, time by t. We're going to group the individuals into groups G equals 1 to G based on a priori types of drugs. So there's variation across groups in disease probabilities and market shares, and the variables are now indexed by G, QGN, N bar G, PGH, and the market shares are indexed by G. The basic idea of the estimation is it's going to be a nested fixed point with maximum likelihood. So we're going to solve the dynamic decision process, and we're going to match up choice predictions to the data. The central complication is that we do not observe all the health shocks, and in fact, we only observe the health shocks when individuals purchase drugs. Modeling of the outside option is central to identification, though. Okay, individuals choose the outside option more in the donut hole. That's just a technical way of stating what I found in all those non-parametric regressions. When you get to the donut hole, people cut back on drugs, right? They don't buy drugs, they're choosing the outside option. The result is a problem with unobserved heterogeneity. It complicates the specification and computation of the likelihood. It means we can't use conditional choice probability estimators such as Hotz and Miller and all the literature that followed there, okay? So to illustrate the likelihood, I'm going to first talk about the likelihood when you know the disease occurrences in the simpler case. So in that case, it's a fairly simple likelihood function. So let NIT indicate the observed health shocks. Then the likelihood for INT can be written as the probability of summed over all the number of health shocks that you saw that health shock given that you had one less. and then or that you didn't see another health shock. And then if you did see it, it's the probability of seeing that health shock, the probability of the particular disease, and the market share predicted by the parameters of predicting the particular drug. Okay. Now the problem is we don't, of course, see all those drugs. Okay, so if we have unknown disease occurrences, then this is what we're going to do. We're going to compute P, the probability of seeing particular diseases, and Q, the probability of seeing particular drug classes from the data on the same enrollees but earlier in the year, and it simplifies the identification and the computation task. And then we're going to specify all the possibilities over when the observed health shocks could have occurred and over the number of health shocks. So for example, if the enrollee purchases drugs A and then B and has a maximum 4 health shocks, that's equivalently to a combinatoric problem of n of 4 choose 2. Okay, and 4 choose 2, there are 6 possibilities to that, with A always before B, 1, 2, 1, 3, 1, 4, 2, 3, 2, 4, and 3, 4. These are the health shocks at which you bought drugs instead of the outside good. So the possible number of health shocks then you have is either, if 1, 2 is the possibility, then you have either 2, 3, or 4 health shocks. If 3 was the last one when you bought an inside good, you have 3 or 4. If 4 was the last one, you have 4, etc. Okay, so conditional on any possibility of when the observed health shocks occur, the model fits the earlier likelihood, and we're going to use methods I developed in a very obscure paper many years ago in the Journal of Economic Dynamics and Control to enumerate the possible health shock times in closed form, and we'll denote this set as script L of n. Okay, and then the likelihood, which looks pretty messy, is not all that messy. All it does, the first term sums over when the observed health shocks occur and the number of health shocks and the probability of seeing this many shocks. The second term looks just like the other likelihood. It's just the probability of seeing the observed drug purchases. And the last term is just the probability of seeing the unobserved health shocks. And we don't know which health shock it is, so we just have to sum over H, which is the possible health shocks you could have gotten. Okay? So let me talk about identification here. So we condition on the price elasticity parameters, alpha. Beta and delta are identified from the aggregate drug purchase probabilities immediately before and further before the donut hole. This is what we argued with the reduced form evidence. And gamma parameters are fixed effects for each drug and can be identified from the cross-section. But a high alpha bar or a low beta delta have similar implications here. Both predict big drops in quantity upon entry into the donut hole. So what identifies alpha bar? Cross-drug and cross-time variation in prices. For example, different drugs have different substitutes within their classes. High price elasticity implies more drops in drugs with lots of substitutes following entry in the donut hole. The overall takeaway is that it's important to estimate the price elasticity accurately to estimate beta and delta accurately. And we believe our multinomial choice model works reasonably well here, and that's why the structural estimation may be a good framework for future stuff. Okay, here are the structural estimation results. The most, what is that? 5, thank you. The most important thing to note is that beta is 0. We find complete myopia from this. Moreover, as we get to a rational model, a myopic model with a high delta and a low beta, we can not reject it necessarily, but as we try to go away from myopia towards a beta of 1, we reject, okay? So why? Because the spending drop upon reaching the donut hole is very large. It's 20–25%. Okay, in the last couple of minutes, let me talk about the counterfactuals. Okay, so what we do here is we use a mix of the estimation sample and other enrollees from our data, and they're chosen so that 33% hit the donut hole, as in 2008 Medicare Part D. So it's 32% our estimation sample and 68% other enrollees in the same plans. We use the middle ACG scores, but the results are robust to the 3 samples we have. We simulate optimizing behavior over 52 weeks, so it's a finite horizon Bellman equation. We explicitly allow for catastrophic coverage, and we use the estimated structural parameters. We're going to examine outcomes in welfare. Welfare measures assumes geometric 5% discounting over the year, and we look at 2 sets of counterfactuals. First, the importance of moral hazard and behavioral hazard, and second, counterfactual policies such as filling the donut hole. In terms of moral hazard and behavioral hazard, what we find is that if you could get rid of the behavioral hazard, if you could make people act rationally, then their spending would go down. And it would go down about 15% here. And because they're spending less, they're getting to the donut hole less, and the insurer spending would hardly go down at all. So total spending, sorry, this is more than 15%. This is like 30%. The total spending would go down 15% in that case. And welfare would go up because people are making better decisions, okay, about 3% or something. Now, if you could get rid of insurance, if you get rid of moral hazard by getting rid of insurance, then spending would drop even more. Okay, so total spending would go down from $42 in the baseline to $33, or a drop of 22%, but of course consumer welfare would be much lower. Okay, so basically what it's saying is that that the behavioral hazard here is almost as important as the moral hazard. Okay, with moral hazard, total spending would decline 22%, but with behavioral hazard, forward-looking consumers would reduce their own spending by 15%, by quite a bit, nonetheless. Okay, now if we close the donut hole, as is legislated to happen under the Affordable Care Act, then what we find is that, of course, people will be better off. Welfare would go up by about 10% or so, 9%. And enrollee spending would drop, and insurer spending would increase. Okay, insurer spending would increase 29%, in fact, so it's quite costly. And total spending would go up about 8%. Okay, because people are going to buy more drugs. So if you wanted to get rid of the donut hole but keep spending constant, then what you'd have to do, we said, what would it take to do that? Currently, coinsurance is 25%, but we find that you'd have to raise it to 42% if we wanted to do that. So it's be a big increase in coinsurance, and it wouldn't be that effective insurance if you have a 42% coinsurance. So bottom line is that closing the donut hole increases the total spending by 7%, or the insurer spending by 29%. Okay, in conclusion, what we've done is we've developed a modeling framework to understand the extent of forward-looking behavior under complex insurance contracts. There's a lot of limitations in what we do. There's no dynamic progression of diseases from drug purchases. The only dynamics are financial. There's no measurement of substitute therapies to drugs or medical benefits. There's no model of physician agency at all. But nonetheless, what we've done is we've developed a simple and we believe robust discontinuity-based test for myopia. It's based on the sample of enrollees who expect to end up in the donut hole. People lower consumption only upon reaching the coverage gap. That supports myopia, but not geometric discounting. We develop a structural estimation framework with hyperbolic discounting. It's the first dynamic drug model with an IO-style multinomial choice model. Our findings are complete myopia, beta equals 0. Behavioral hazard is quantitatively important, 15% drop in spending from rational agents, and 22% drop in total spending with no insurance. Closing the donut hole implies that there'd be a 29% increase in insurer spending with the same coinsurance, or a 42% coinsurance if we want budget neutrality. Okay? I'm done. Creo que hay algunos minutos para las preguntas, ¿sí?
Well, I do have a question. Something we talked about briefly before the talk, which is that, well, what you find in the data is that people stop spending drastically when they hit the donut hole, which is arguably irrational. Because otherwise they would plan ahead. I mean, they knew for sure they were going to hit the donut hole, that they would plan ahead and they would just drop their their spending before reaching the threshold. But then I was wondering whether what room these people have for storing their purchases, in the sense that it might look that they're irrational because their purchases drop drastically when they reach the threshold, but it may be that they're just storing what they get, and maybe they're smoothing their actual consumption in a more rational way.
Okay, so that's an excellent point. And so one of the things we could do about it is that mostly the people who are hitting the donut hole early in the year. Now, some people are hitting the donut hole at the end of the year, where it might make sense. So the only reason that you would drop your consumption upon hitting the donut hole, for instance, is if you store your drugs so that you get right up to the donut hole and then you stop, right? That would be a rational dynamic strategy, is you think like, well, next year, maybe I'm going to end up in the donut hole, I'm going to be sicker. So this year I'm sort of I don't want to leave this margin. So I'm going to go to the doctor and say, my back hurts, my head hurts, give me all the opioids, right now. And so give me all the opioids and I'm just going to store them. Or maybe the doctor does it with you and the doctor says, let me give you a prescription for opioids. Just keep it, just fill it, keep it. And next year when you need the opioids, you don't have to pay for it because you're not in the donut hole. But if that was the case, then what we'd end up is that there'd be all these people clumped right at the donut hole margin, right? And so the fact that that the histogram does not show this clumping says that that has got to be a negligible portion of the people, and that's an excellent point to make in it, right? Okay, thank you.
Are there any other questions?